The exemplary professional practice piece in the magnet model, that's where we demonstrate that we really are having quality outcomes, and not only just in the clinical side, which is sort of the hard side, the science side, but in the satisfaction piece too. We want our patients' experience, the experience that our families have, to be the best that it could possibly be.
The vascular access department started out as the IV team. We started out as a 4-member team, 2 night people and 2 day people. And our function was basically to start peripheral IVs. We started originally in response to patient and parent complaints. When you have an invasive procedure and anything that involves a needle in a kid, you know, it's not really, those two don't go together really well. In response to that, they wanted a central group of people who did nothing but that, so that their skill level was a step above what the average nurse would be, to give the patient a better experience with that. It has since grown into something a little bit more. We now have 14 members of the team. The PIV is still a very important aspect of it, but on top of that, we have incorporated inserting PICC lines. A PICC line is a central line. An infection in that line is a very bad thing to get. And so when you've got a core group of people who are monitoring those lines, cleaning them, changing the dressing on them, checking them to make sure there's no sign of infection, then you have tenfold elevated their safety. We modeled most of the things that we do after the Infusion Nurse Society, and the Infusion Nurse Society recommends sonography for finding veins, especially with the PICC line insertion. It's kind of the gold standard. The sonograms that we use are specific for vascular access. We have 2 of the machines now because we have so many lines that we're putting in. We'll have a team do one and another team do another. Our success rate with our PICC lines went from about 85%, 85%, to now we're about 95%. Not only does it help the patient, but it also helps the staff in the hospital. We come in, we do this aspect of the patient care that frees up the patient's nurse to go do medications, whatever else she's got to do with the patient.
A few years ago when I was doing my master's project, you know, you need a project, I focused on wound care education and sort of baseline education for wound and skin care, and it just sort of morphed from there. Eventually we built a team and got that all started, and then we got the approval for a position. And prior to me getting this position, if somebody needed wound care, we have always contracted that care. I always thought that was kind of strange because we're such a good facility. So what I've done, it's called the SWAT team, Skin and Wound Action Team, and there's 62 members, so it's throughout the whole facility that I'm just training on basic wound and skin care, training them on products, creams, you know, dressings and stuff like that, so that they can be the first line of defense on the floors. A wound can cost up to $70,000 to manage it. So not only are you taking the cost into consideration, secondly, there's pain involved with wounds, regardless of what stage it is or what kind or what caused it. Depending on where the wound is and how old the child is, there's psychological effects that come into play with it. If they have a wound on the back of their head, they're going to lose their hair in that spot for a while, maybe forever. Parents, that's not what they expect when they bring their kiddos in here. They want good stuff to happen and they get better and go home. The education that I'm trying to get out there, they can make the right choices, which increases the quality of the care that we give the patient.